Peak week, getting hard off oral anabolic steroids. Which ones to use? I am John Jewett with J3 University, and we elevate the coaching standard. Today, we're going to dive into peaking with PEDs and orals and holding water. And this is the big one really with PEDs is water retention. And when you're going into peak week or even right before it, we have some considerations around the deployment of what we're doing with anabolics and other PEDs that might be driving this water retention to occur. And if we understand how it works, it should give us some guidance into what we should be using to modulate this effect, to bring the really hard, grainy physique to stage. And so to understand and have to be a nerd about what to use, you have to know a little bit about how things work. And one thing is, well, why do we hold water to begin with when using PEDs? And part of the and this is going to be a more simplified version around this, is that the kidneys contain receptors for growth hormone, IGF-1, androgens, estrogens. All these things, when they bind to these sites, can activate the renin-angiotensin-aldosterone system. It's this long cascade that causes a lot of different hormones to get released. End point being is that aldosterone rises, which attaches to the mineralocorticoid receptor, and this causes changes in fluid dynamics, sodium reabsorption, and water to be retained. That's why we see this water retention to occur. It's also usually with certain compounds that fit these classes that bind here to these sites, increases in blood pressure and also concomitant increases in water retention. Now, these might not be as profound if you're really, really lean, but you'll know it's probably more problematic when you're in the off-season state, a little bit more body fat on you. Definitely can notice more of the water retention occurring. Now, another component around PEDs too, when we put them all as a whole, is your lipolytic agents. So say you're taking some clenbuterol or yohimbine. For one, they can just drive up anxiety, impact sleep, make it decline. That in and of itself could drive up cortisol. If you listen to one of our past videos around fatigue management, cortisol in and of itself can drive up water retention to occur. So we have lots of things to consider around which compounds are impacting water retention. And if we know how these interactions occur, we can know what to do with arranging the stack design. All this is going to depend on what type of compound it is. So if it's anabolic, androgenic, steroid, each one has a little bit different function, right? Like a lot of times using Masteron, you're not retaining a bunch of water, like if say using testosterone. They differ, right? Same thing in the dosage. You could use 100 milligrams of testosterone. You might not see any issues. Comparatively to using 1,000 milligrams, you're going to see a lot different type of input for water retention. Then the individual response. I've seen clients where before I use the growth hormone, they just look full and hard. It's like no change. Or I've had other guys on 4IUs and they still have water on them. You remove that growth hormone, they get stage lean hard. So don't think there's a generalized approach to using this type of PED stack design is what's going to bring a hard physique to stage, because what matters is the balance between hard and also full. It's a full package that we're trying to bring, not just a glute show. We're not chasing the last glute line. If you do that, you might lose sight of the whole picture of his physique. So an assessment needs to take place. And I think that's what's lacking a lot of times in our coaching realm, is that we're just giving out protocols of like at 10 days out, you cut test. At 5 days out, you cut growth hormone. At this many days out, you add in anastrozole. And it's just given across the board to where that's what's just passed down, and it's now like a little bit dogmatic of an approach. But we need to assess them. So if someone's stage lean, likely they're going to have a low amount of water retention to occur anyway. And I think this is the problem with the guys using a lot of compounds in prep that drive water. You end up blurring your assessment a bit to where it's hard to know, is it water or if it's fat? Then they wait last minute to make that test and they drop water and they're still fat. So along the way, we should be addressing some of the water retention components in your stack designs to be able to draw out, is it body fat or if it's water? Different conversation for another day. We also need to assess the balance and the look, right? Because we know they need to be lean, but we want the look to be full and hard. So for some people, they might have X amount of test in, X amount of growth hormone in, and they look amazing like they could walk on stage. Don't change it. Don't change it. Leave it the same. Run it all the way into the show. That's perfectly fine to do. Now, you might have someone else where they still don't look hard, and you're going to have to do more manipulations to occur. But again, it should be individualized for that person. Once you run them through a protocol once, you're gonna have a pretty good idea of what they take to get down to a hard stage condition. And then we can make adjustments in this too. If we need someone that's that guy that gets really grainy hard, but usually fullness is an issue, well, let's leverage the drugs that drive up more fullness. Maybe we actually bring in something like an anadrol, or maybe we leave a bit more growth hormone in. While you might have someone that's really full and round and it's hardness that's the issue, we need to pull back more on the growth hormone or the testosterones, and a thing to consider. But one misconception that I see a lot, and the one we're going to address today, is around orals. And it's, when is it time to add in the hardener? And this is part of the problem, is that orals, if we just remove the name hardener from them, it would make them a lot clearer of how they get deployed. Because I've seen bikini girls ask like, hey, can I add in Provirone because I want to get hard? Like, Provirone is a fat loss agent. Like, I would need to lose body fat, I'm going to add in Provirone or Anavar or something. So this gives the incorrect connotation around what the compounds actually do. And very simple, like, know your main mechanism of action of all the anabolic androgenic steroids. Their main action is working for protein accretion, preventing protein breakdown, muscle breakdown, via the androgen receptor. They're binding to that receptor, and that's the process. That is their main thing that they do. Now, they do some few other little indirect things, but that's the main one. So we should say, if that's their main thing they do, that's going to be the main reason to use them. And then we should have measurement tools to say, how do we know that they're doing their job enough? And do we need more? That's really the question around it. Now, other things that they do is force production. They're really good at it. Via the endothelial growth factor receptor, which is another receptor that drives force production and type 2 muscle fibers. So this is when you see, like, man, I get a performance boost out of when I take halotestin before training, or Anavar. Part of that is its action on this particular receptor site, and an indirect action from the androgen receptor. Now, I would question, how would they work to make you harder? Because if they're going to be a hardener, we're going to say, like, this is why you put an oral in place. Well, how does it work? And so, does it make you lose body fat? And we say, well, yeah, they do a little, they have some role in that. Like, there's some indirect actions, some synergies that take place, but that's not the best use of the compound, right? Well, if it's not making you lose body fat, it must change something around water. How does it modulate water? Well, is it by lowering cortisol? Well, some have some impact around cortisol. We know testosterone could lower cortisol. We know Trenbolone has a major action around cortisol. What's the main issue with cortisol? Well, it's from fatigue, right? You're sleeping terrible. Should you add in more Trenbolone when you're already sleeping terrible? That's not going to fix the problem. Or is it from training, doing 20 sets of squats, or from doing hard cardio? Like, you should be addressing the root issue, which is cortisol. So we know an oral steroid is not going to make you hard through addressing that means, that action. What about estrogen, right? It might be the issue is that you have a high amount of aromatizing compounds in place, and by lowering estrogen, offsetting the androgen to estrogen ratio, that by all means, it could be by, for one, being some type of competitiveness with the aromatase enzyme. It could be more so around actual affecting estrogen DNA transcription processes and how the androgens interact in that process to offset estrogen. Maybe so. That might be a way you get a bit harder. Rather than adding an oral, why don't we just lower the aromatizing compounds? Maybe replace them with the non-aromatizing androgen. This is something you could do weeks before peak week. Now, the last thing we would say, well, what else causes water retention? Aldosterone. We talked about our mechanisms of how a lot of these compounds will bind to the kidney and drive up the renin-angiotensin system, right? So we could start just by altering stack design rather than adding in more drug. So if we know, like, say, nandrolones, testosterones, growth hormones, all these things drive up more water retention. If that's part of the issue, well, let's modulate. Let's change our stack design rather than add an oral in for that. So that kind of leaves the question is, for one, well, do the compounds differ between all these orals that we see that are hardeners, right? Oxandrolone, halotestins, stenazolol, Provirone, oxymethionolone, do they differ? And they do differ slightly. I would put in my main list ones that you could probably source from an actual pharmacy. Primarily, oxandrolone would be the main one to leverage, and then going down from that point. I won't go into each action and how you might deploy each, but for the most part, a lot of these And we're going to primarily, for going into a show, we're looking at Anavar, we're looking at Winstrol, we're looking at halotestin as main ones. They all bring about a non-aromatizing compound that's offsetting estrogen and raising our androgen total stack design. Now, when should we be utilizing these? That's when we have the main assessment of what do they do. What do the main anabolic steroids do? They drive up protein accretion. They prevent protein breakdown. What's our best indirect measure that's happening is gym performance. That's it. So when you're seeing the later parts of prep, gym performance is it's hard to hold on. And we only have a few weeks of this before we go to our show. We don't have time for a lot of these injectables to take action because they take a few weeks to climb up in our system, right? To raise serum levels. But orals can be deployed immediately to have that action take place and drive up training performance. You increase training performance, it's going to be a good stimulus for muscle retention. This is our main assessment tool for when we should be using an oral. Now from there, which one to pick is another conversation. And I would rotate through and try some different ones to see which one is the best for you, as there's going to be individual response variations within these. And some are going to cater really well to an individual. Now, there's some on here that won't make a lot of sense to use. One like Anadrol, which could cause more water retention to drive up, but it might have application for that, guys. That's very, very hard. Provirone, just in general, is not a huge favorable one, as it doesn't do a lot around protein accretion and protein breakdown. It might drive up some performance, but it doesn't have a lot of action around skeletal muscle via the androgen receptor. So it still kind of comes down like between Anavar, halotestin, and Winstrol. Pick the best ones that action for you around gym performance, as these compounds should not be considered hardeners. They happen to might do that, but through the routes that we just talked about, where we have other things that we can play to address it. So you end up getting the right outcome for deploying your orals sometimes, but it's for the wrong reasons. Into peak week, your last weeks of stage, make sure you're deploying orals in the right sense so you don't end up using 4 or 5 different orals because you don't know which one's doing what or why you're applying which. You know the mechanisms, how to assess it, then when to deploy it, and that's where you can understand an actual individualized process for PED design. If you want to learn more, head to j3university.com and we'll deep dive into PEDs. Till next time, we'll talk to you then.